All right, well, it looks like a few more people have jumped on, so I will go ahead and get us started and just run through a few little ground rules. So for those of you on the attendees list that I don't know, my name is Jeff Gaines. I'm the Chief Medical Officer here at Newport Hospital, and I'm excited to have Dr. Samuel Eaton, who is our urologist here, to go through a little presentation. So I'll give him a little intro in a minute. Just a few things if you haven't been on the community lecture series before. Right now, this is kind of a webinar format, which means you don't have the opportunity to unmute and be able to speak just yet. So I would ask you to please take a look at the bottom of your screen, as if it looks like mine. You have two things. You have a chat box, which you're welcome to put information into, and you can select who you send the chats to. And there's also a Q&A box, a question and answer box. So you can use either one of those. The question and answers you can put in, and people don't see the question until we release them. The chat box, people can see them right away. Either one's really fine with me. And what I'll do is I'll act as moderator. So as questions come up, even while Dr. Eaton is speaking, we can certainly take a little breather, and I can pop in questions if they come up. And then at the end of the presentation, hopefully we'll have a little bit of time for Q&A. So please take this opportunity to speak to a world-class urologist who's here, not only local in Newport and taking care of patients here locally, but tied in with the Minimally Invasive Urology Institute within Lifespan and up at the Miriam. So he has a ton of expertise, and I think hopefully there'll be some good questions. I have a few of my own. So we'll try to hopefully get to those as well. But just by way of introduction, Dr. Eaton has a presentation to talk a little bit about BPH and some of the treatments that he does for that, as well as some treatments and some options that he has for prostate cancer, and maybe a few other topics if people have an interest. He is a board certified urologist. As I mentioned, he's a member of the Minimally Invasive Urologic Institute, which is really active at the Miriam Hospital. And he has the ability to be able to manage patients here in Newport and do some cases up at Miriam as well. They have a pretty fancy robot up there that we don't have, so he can do some robotic surgery, and that's one of his areas of specialty, robotic and laparoscopic surgery, hence the minimally invasive part. As I mentioned, he does manage prostate cancer, kidney cancer, upper urinary tract reconstruction, stone management and obstruction issues. And then, of course, as we're talking about tonight, BPH and the surgery that goes along with prostatic hypertrophy, which is all too common, unfortunately, in men. Certainly does treatments for women as well. So we can talk a little bit about that. Should there be audience members that are interested in that as well. We ripped him off. He was an assistant professor at Duke, and we were happy to get him here and bring him on board, which is great. He did his internship and residency at Boston University and did a fellowship at Northwestern before heading over to Duke. So he has quite the credentials, if you will, on the academic side. And so he does some teaching and things with the Brown Urology group of part of Brown Physicians, and worked with the residents as well. And full disclosure, we're working on trying to get him some gadgets and things to be able to even expand some of the resources and the treatments that he can do, because he does some pretty fancy prostate procedures that currently nobody in the state of Rhode Island is doing. So his level of expertise is really has the possibility to bring the whole state of Rhode Island to a whole nother level. And certainly within Brown and within Lifespan, we're super excited about that. So more to come on that. We can talk about that at the end if you'd like, but I will hand it over to Sam Eaton, our distinguished urologist. So thank you for joining us today. Appreciate it. And please, for the attendees, feel free to fire things off in the chat or in the Q&A. And if there's a lot of interesting questions, I can also unmute you, allow you to be able to speak once Dr. Eaton's done presenting, and we can go that way as well. So thanks, Sam. Appreciate it.
Yeah, great. Thanks so much, Jeff. It was a great introduction, and happy to be here in Newport, and happy to have the opportunity to talk to you about one of the topics that I deal with a lot and care about. So happy to talk about it, and as you said, and any questions that come along, happy to answer those. So he talked to you a little bit about what I do. Basically my specialty is in minimally invasive surgery, as he said, which is referred to as endourology. In my main areas of focus, he mentioned, but minimally invasive surgery, BPH management, prostate cancer, kidney cancer, and kidney stones. And I take a lot of pride in being able to, try and offer procedures and interventions that really minimize the risks to patients and, really allow people to get back to their, regular day-to-day living as fast as they can. And that's sort of why I wound up choosing this path, because it really allows us to help people and do it in a way that gets you back to hopefully regular living as quickly as possible. So I'm going to talk a little bit about general urinary function issues, and then talk a little bit about prostate cancer screening and treatment, because it can often be related to some of the issues regarding BPH or benign prostatic hypertrophy. And then we'll go into talking about BPH, what it is, what it does, and the best ways to manage it. So briefly, this may not be news to most people, but it's good to have a sort of basic understanding of what goes on and what we're dealing with. So, the areas that I focus on are basically the urinary tract, which starts with the kidneys. They filter waste from the bloodstream. That waste becomes urine. And then the ureters are the tubes that transport that urine to the bladder. And then the bladder is what stores the urine. It's found in all terrestrial mammals. So it's a conserved function throughout all mammals that live on land. And the evolution of it, as opposed to just emptying your urine without storing it, it actually was to try and limit the deposition of scent, so that the prey would not give away their location to predators. It's a little more important to us now in terms of continence and social concerns, but it's kind of interesting to see where it came from. And some of the basics as to how the bladder works, and I think this is important to sort of understand how things go wrong. Basically, the bladder has two functions. One is to store urine. The other is to eliminate urine, which is what we consider urination. And at its most simple, it's essentially physics. And so if the pressure on the bladder is less than the resistance provided by things like the urinary sphincters, then it's performing a storage function and it retains urine. If that pressure in the bladder overcomes that resistance, then you're eliminating urine. And sort of understanding that at its most basic level allows you to sort of understand how things can sometimes go wrong. So under normal circumstances, you store urine until you're ready to go to the bathroom. The bladder contracts, and then the internal and external sphincters, and this is a diagram of a female urethra, relax, and you empty your bladder. And so that's how things work when things are working well. So as we know, things don't always work well. And the main issues that can happen relating to those functions are issues with retention, meaning that you're not able to empty the bladder as well as you need to, or incontinence, meaning that you can't control the emptying of your bladder as well as you need to. And sometimes these things exist on their own. Sometimes they can exist together, where you can have issues with both retention as well as incontinence, which can be very bothersome. When we look at retention, it can be due to a number of different things. But going back to the physics, it can either be poor bladder function, meaning the bladder isn't able to contract and push the way that it needs to, or increased resistance, which means that for whatever reason, the urethra is not able to relax and accommodate the flow of urine. That can be due to BPH, which is what we're going to talk about mostly today. But there are other things such as strictures or scar tissue in the urethra, as well as issues with the functioning of those sphincter muscles that I talked about. And those are the muscles that you use to hold your urine when you need to have that, when you have that urge to go. And moving to incontinence, so this can be due to different issues as well. And essentially, it's the converse of retention. So if your bladder is pushing too hard or when it's not supposed to, you can have leakage of urine. Or if your resistance is not enough to overcome that pressure in the bladder, then you can also have leakage of urine. And the two different types of incontinence, from bladder overactivity, we usually refer to as urge, meaning that urge to go causes incontinence, or stress incontinence, where we see cough with stress, strain, or increased pressure on the abdomen. There's another type of incontinence called overflow, which basically means that the bladder gets so full that your ability to resist the flow of urine is overwhelmed, and that can also cause leakage even though the bladder is full. So knowing how the bladder works and how it can be problematic, another thing that's important to understand is, what is the prostate? And it's one of these organs that you don't really think about until it's a problem, but there can be a lot of issues associated with it. Its normal function, it surrounds the urethra. It's an excretory organ, meaning that it contributes fluid to the ejaculate, so it plays a critical role in reproductive function. As men get older, unfortunately, when that reproductive function is usually less of an issue, it can also cause problems. And the reason why it causes problems is that the prostate is one of the few organs in your body that doesn't stop growing over time. So even though your height stops growing, most of your other organs, your bones stop growing, your prostate continues to grow. And, from a normal size when you're young, it slowly grows over time, where the average size at age 60 goes from about a walnut to a golf ball, and sometimes can even be the size of a tennis ball or larger as it starts to cause problems. And what happens is that as that prostate grows, the urethra, which goes through the prostate, can become constricted. So on this right figure, you can see as the prostate grows, it constricts the urethra. And as you can imagine, that's going to make it a lot harder to go to the bathroom. And symptoms that are consistent with this enlargement are problems with slowing of the stream, a sensation of incomplete emptying, stream starting and stopping, or even not being able to go at all. Additionally, as the bladder responds, initially it can overcome this growth by becoming stronger and pushing harder, but that can cause changes within the bladder too that can lead to issues like frequency, getting up at night, and urgency as the bladder is trying to work against this increased resistance. And one of the things to remember, and why it's important if you start having these symptoms to consult a doctor, is that BPH is a benign thing, and when it becomes severe, it needs treatment. But sometimes these symptoms aren't a sign of just enlargement of the prostate. Sometimes it can be due to scar tissue. Sometimes the bladder may not be functioning well. Sometimes it can be just overactive bladder, but it can also be more serious problems like things like bladder cancer, prostate cancer, or stones that may need more urgent treatment. And I wanted to talk a little bit about prostate cancer because that's the second most common issue that can affect the prostate, and issues with enlargement of the prostate and prostate cancer can often go hand in hand. And additionally, prostate cancer can also mimic some of the symptoms of prostate enlargement. And prostate enlargement happens to every man as they get older. That is inevitable. Prostate cancer isn't that inevitable, but it is very common. So in men, it is by far the most common cause of malignancy. And it's this slide on the right is a little bit difficult to read, but it's also the second leading cause of death from malignancy. And one of the issues, though, that we deal with, and as you can see, is that there's really nothing that comes close in terms of the numbers of people with prostate cancer. But many people with prostate cancer don't die of it, and that's a good thing, but it can sometimes make treatment decisions difficult. Our main tool to look for prostate cancer is PSA. PSA, I think a lot of people have heard of. It stands for prostate-specific antigen, and it came about in the early 1990s, and was hailed as this wonderful solution for identifying prostate cancer at an earlier and more treatable stage. And it is that to a certain extent. But over the years, it's caused some controversy because of some of the issues associated with it. So even though it's fairly sensitive at identifying prostate cancer, meaning that it's able to identify a large proportion of early prostate cancers, it can also have significant false positives, including being elevated from just BPH. It can also have significant false negatives, meaning that you may miss some significant cancers. And one of the other issues is that there's some prostate cancer that you really don't need to find, meaning that it may be so slow growing that it may never affect someone during their natural lifetime. And in situations like that, there may not be a benefit in identifying it, and it can cause stress, potentially unnecessary treatments, and things like that. So, these issues have made it a fairly controversial test. Now, some of you may have heard about this, and this is sort of in relation to the controversy. The U.S. Preventative Services Task Force is a group that has been tasked by the government to identify preventative treatments and testing that are either beneficial or not, and provide recommendations to the country over how they should be used. And as you can imagine, they can have a fairly big impact on practice patterns. Over the course of the years in the 2000s, the PSA test came under the scrutiny of the U.S. Preventative Services Task Force. And initially in 2008, they recommended against PSA screening in those over 75 with the rationale that people who are older are more likely to be misidentified as having prostate cancer and being over tested, and also the risk of finding prostate cancers that may not affect people's mortality. And then in 2012, they came out with a wholesale recommendation against routine PSA screening. And they cited poor data in support of screening, as well as the risks of overtreatment and additional testing. The problem, though, is that recommending against something is easy, but the issue is there isn't really, or at least wasn't at the time, a good alternative way to reliably diagnose prostate cancer, and it's still the second leading cancer killer in men. And even though the data and the risks may not be perfect, if you look at the statistics over the course of a number of years within the United States, it's clear that PSA screening has had an impact. So on the top line in blue, you can see what's called the incidence rate, meaning the number of people per year who are diagnosed with prostate cancer. And you can see in the early 1990s, there was a huge spike in the incidence of prostate cancer. And the reason for that was that PSA all of a sudden was able to identify a much larger number of people who had prostate cancer. Now, that increase didn't last because essentially what you were doing was identifying people who would have shown up later, but you're catching them earlier. So the overall incidence sort of flattened off and plateaued roughly along the previous slope of where diagnosis was happening. And then in the late 2000s, around 2008, and going through 2012, you've seen a huge drop off in the incidence of prostate cancer. And that's because these recommendations have led to a significant decrease in screening. Now, in the past few years, the U.S. Preventative Services Task Force has changed their tune a little bit and allowed more room for the possibility of screening, and you can see those numbers are ticking up. And you can see that that's had an effect. So prostate cancer mortality was sort of slowly increasing in the United States up until the early 1990s. And then, since the addition of PSA screening, you saw a slow decrease over time. But you can see that since the PSA recommendations have come in place, the slope of that line has sort of leveled off. And that's probably because less people are being screened and identified early. So certainly controversial, but I think, the data now suggests that getting rid of PSA screening is not a good idea. And over the course of the past 10 years, we've also made a lot of strides in improving our ability to diagnose, screen, and manage prostate cancer. There are improved diagnostic markers. So for those people who are identified as having a high PSA, we know that not all of those people necessarily need a biopsy. And there's a number of additional tests that we can use to really work on identifying those people with higher risk types of cancer who really are going to need and benefit from treatment, and trying to minimize the number of unnecessary tests and biopsies that we perform. The other thing that a lot of work has been done on is improving our ability to predict what's going to happen. So for those people who are identified with prostate cancer, we know that not all of those people need treatment, and protocols have been instituted for those who look like they may have insignificant cancer to just watch as opposed to treating immediately, which reduces some of those risks of treatment. And then finally, we've seen improvements in treatment over the course of the years, which lead to less risk from the treatment. What I do, robotic prostatectomy, has led to significant improvements in recovery time, as well as some improvements in urinary control and things like that, which make issues after treatment less significant. Additionally, radiation, which is another treatment for prostate cancer, has improved significantly, where they're able to better target just the prostate and reduce unintended side effects. So we're doing a better job of identifying people who really need treatment and a better job of minimizing the risks to those who undergo treatments for prostate cancer. And now we're going to talk a little bit about BPH now. And for some reason my slides got changed here. Hang on. All right. Well, so we'll talk about BPH management, and essentially there's different options for management of BPH, and sometimes it's just observation. Some people with early symptoms of prostate enlargement may not need treatment at all, but may just need reassurance that these issues are really just coming from normal benign enlargement of the prostate, as opposed to something that might be more worrisome, like prostate cancer. There's also medications that can be effective for BPH, especially early on, that can really help people who are starting to have symptoms. And for those people who don't respond to medications, or who have significant side effects or problems with those, there are different surgical options for management. And, they're very effective. They usually have relatively minor risks. And for those risks that do exist, there are options for managing those depending on patients' priorities and needs. So, for people who are having symptoms from prostate enlargement, I think the important thing to know is that there are a lot of options that are out there, and being able to work with your physician to identify the right choice for you is important. So there's also a lot of marketing out there, and it can be sometimes difficult to really separate what's important with what's just marketing. And I think that also just, reiterates the need to have a real detailed conversation with your physician or urologist about the options that are available, and make sure that you tell them what's important to you. Because what's important for one person may not be for another, and that plays a big role in terms of how we determine what treatments we might choose. So part of it is the clinical factors, but a lot of it is what a patient's priorities are. In terms of medical therapies for BPH, the mainstay for initial treatment is usually alpha blocker therapy. And what that means is that it blocks smooth muscle function within the prostate. And what that does is that it relaxes that smooth muscle, allows decreased resistance to the flow of urine, improved emptying, and it tends to be very effective for the management of symptoms. And the advantage of these medications is that they work pretty quickly. Usually within a week or so of starting these, patients are going to notice a benefit, and often much sooner. There are some issues with these medications. While they affect your symptoms, they don't alter the process that's causing those symptoms, meaning the growth of the prostate. And as the prostate continues to grow, they may lose their effectiveness. Also, some patients do have significant side effects from these medications. The most common ones are dizziness or lightheadedness. Also something called retrograde ejaculation, which can be bothersome to some patients, and sometimes nasal congestion can be an issue. Sometimes if you're having side effects, just changing the medication can be effective. So it's important that if you do need to stop a medication due to these side effects, that you talk to your doctor about other options that are available. Another medication which has more recently come out is tadalafil or Cialis. So the original indication for this is for erectile dysfunction. And interestingly, as they continued to use this with erectile dysfunction, it was noticed that a lot of patients noticed improvements in their urinary function as well. And similarly, the Cialis or tadalafil relaxes smooth muscles and can be effective alone or in combination with alpha blockers. They are probably less effective than the alpha blocker medications, but in some people they do work very well. Main side effects are things like headache and muscle pain, but most people tolerate them fairly well. The other mainstay of treatment for prostate-directed treatment are medications called 5-alpha reductase inhibitors, such as finasteride or dutasteride. These medications block the conversion of testosterone to dihydrotestosterone, and basically what that does is it deprives the prostate of one of the main signals that causes it to grow. And this leads to decrease in size of the prostate and has been shown to decrease need for surgery when it's combined with alpha blockers. There are some issues with these medications. One is that because they're working to shrink the prostate, they take time to work, and it can be 6 months or sometimes more before patients really notice a significant benefit. It also can cause changes to PSA, which is important to know for people who are monitoring your PSA. So your PSA will decrease when you're on these medications, and it's important to adjust for that when people are monitoring you. They can sometimes cause sexual side effects, such as erectile dysfunction, also can sometimes cause gynecomastia or breast enlargement. And there's some question that it may increase the risk of aggressive prostate cancer, although the data on that are still unclear, but it has limited some of the use of these medications. So the other medications that we can use are directed at the bladder or storage symptoms. And sometimes these medications can be effective, usually again in combination with the prostate-directed medication. These medications decrease bladder muscle excitation. and decrease the urgency and frequency that can be experienced by people with enlarged prostate. They're also very effective for other people with overactive bladder and are used frequently in women for urgency and urge incontinence issues. They do not improve emptying. And in fact, in some cases, if people are having difficulty emptying completely, can cause retention. So that's important to monitor. These medications also can cause cognitive side effects, especially in the elderly, and need to be used extremely carefully. They do also take time to work. Sometimes can be a couple of months before people really start noticing a benefit. Main side effects are constipation or dry mouth. There's also a newer medication called mirabegron. It targets a different receptor, but works similarly to anticholinergics. It has advantages of less dry mouth, less constipation, less urinary retention. Also seems to cause less cognitive side effects, so can be beneficial in older patients who may have bad side effects from the more standard medications. The downside is that it is more expensive since it's a newer drug and sometimes is poorly covered by insurance, and also can sometimes lead to high blood pressure issues, which of course is a common problem. So there are some sort of general risks of medical therapy, and one of the issues is that these medications that we start for enlarged prostate tend to be long term. Once you start on a medication, it's usually something that you stay on until either it stops working and you need surgery, or essentially forever. And there are some data that are coming out now that long-term exposure to these medications may cause issues. So if you look at the graph on the right, it shows risk of heart failure over time. And in the first few years, you don't see any large differences, but over time for people who are taking alpha blocker medications, as well as the 5-alpha reductase medications, is your risk of heart failure does go up significantly. It's still low, so these medications are still safe, but there is some risk in taking these medications more long term. And that's something to think about when you know that this is a medication that is not going to be short-term therapy. And that leads us to surgical therapies and surgical options. And these tend to be very effective and often can allow people to avoid having to take long-term medication. So that's always something that needs to be balanced in terms of the risks of surgery and the benefits of avoiding surgery that you may not need versus some of the risks of taking medications for the long term. The concepts of these treatments overall are to try and reduce the size of the prostate or alter the anatomy of the prostate to allow better emptying, or possibly a combination of those things. So there have been a number of surgical treatments for BPH that have come out over the years, and since it's such a common problem, there's a lot of people who have come up with different solutions. And this, dates back even to the early 1900s and earlier. In the early 1900s, they developed this tool called a punch resectoscope, which sounds about as scary as it looks. And it was effective at removing prostate tissue, but patients were often in the hospital for weeks with bleeding issues and things like that. And as you can imagine, it wasn't the perfect solution. In the early 1930s, as equipment improved and our ability to visualize with cameras improved, they came out with the transurethral resection of the prostate, which is the TURP. And this has been around for a long time and still exists and is still an excellent treatment for enlargement of the prostate. There have been some changes and improvements, but the concept is still the same, and it works well. Starting in the 80s and 90s, there were a lot of developments of new techniques, including the use of microwaves, the use of electrical current to remove excess prostate tissue, as well as the use of lasers to remove prostate tissue. And as things have gone on, there have been even some less invasive procedures that don't involve actual removal of the prostate, but things like urolift, which we'll talk about, which tacks open the prostate, Resume, which uses steam to cause shrinkage of the prostate. There's also procedures to eliminate the blood supply of the prostate to cause it to shrink, as well as enucleation of the prostate, which is a newer technique utilizing the laser to improve upon some of the results from the TURP. And we'll talk about a lot of these. And this is a very busy slide, which is intentionally busy just to sort of reiterate how many options there are in terms of surgical treatment of the prostate. And I'll talk about some of the most important of these. So again, these fall into those three categories of either strictly reducing the size, strictly altering the anatomy, or using doing a combination of both. And most of the more standard procedures use a combination of both. So when we think about all of these procedures and all of these options, it can be a little bit overwhelming. Frankly, both for providers and surgeons, as well as for patients. And so I think it's important to think about what matters, what's important when we're thinking about this. So clearly, effectiveness matters. So you want something that works. And we sort of divide our thoughts on effectiveness in terms of short-term effectiveness, meaning how well does it work initially? I'm sorry. As well as the long-term effectiveness. How long is this going to be effective? And it's important to recognize that all treatments carry the potential need for reintervention. And all treatments have potential side effects. Urinary side effects, sexual side effects, as well as the standard surgical risks. And all of these things are important to consider. And most of these procedures can be done with relatively minor risks, but it's important to consider them. So we talked about TURP, or transurethral resection of the prostate. This is the procedure that has been around the longest, and it's still considered what we call the gold standard, meaning this is what all other treatments tend to be compared to. Over time, the safety has improved with the addition of saline and bipolar technology, which reduces some of the risks. And there are some good advantages to this procedure. As a field, we have a very long experience with this procedure. It's well established. The results are well established. And it's something that most urologists are familiar with and are very comfortable with. It's a relatively straightforward procedure, but obviously requires some expertise. There are some downsides to this procedure. So one is that compared to some of the other procedures, it can cause more bleeding issues. And because of that, it usually requires a hospital stay, at least overnight, to run irrigation through the bladder. There's also a complication called TUR syndrome, which used to occur due to absorption of fluid, but this happens much less frequently with the bipolar technology. Prostate ablation is another procedure that usually involves a laser that instead of removing the tissue, you go in with a camera and using a laser to destroy it. And basically remove that tissue around the prostate and open up a channel similar to the transurethral resection. And this is an effective treatment as well. It may not provide as complete a resection because of the way that you're doing it, where you're removing the tissue sort of from the inside out. But it is very effective, and it's relatively durable. The other procedure that we use is prostate enucleation, and this is the procedure that Dr. Gaines mentioned that we're working on introducing here in Rhode Island. And this is a procedure that I have a lot of experience with, and it has some significant advantages over some of the other standard types of procedures. So one, because of the technique of how you do it, instead of sort of removing tissue from the inside out, you remove tissue along the edge of the prostate, and it allows you to more completely remove that tissue. And this technique has advantages because of that. One, it allows us to effectively treat larger prostates in a minimally invasive way and in a more efficient way. And two, is that because you're offering a more complete removal of tissue, it has the potential to be more durable. The other advantage of this technique is that because of the types of lasers that we use, there's less penetration of energy into the tissue, which can lead to less side effects. And the control of bleeding is much improved. And so what we see is that there's less bleeding compared to transurethral resection, which allows for same-day discharge in most of our cases. It seems to be more durable, and that's probably, as I said, because of the more complete tissue removal. It's also more versatile, as I said, because of the technique. It can be used for larger prostates. And in these larger prostates, we compare it not just to TURP, but for the very large prostates, it can avoid the need for a more significant surgical removal, which involves incisions either through an open or robotic technique. So the advantages there are even more significant. And I want to talk a little bit about lasers, because I think everyone in their mind knows what a laser is, but maybe doesn't think about exactly how a laser works. And how that laser works is important to me, because how I choose what laser to use and how it works affects how my surgery is going to go. And essentially, lasers utilize a highly focused light energy, which is converted into thermal or heat energy when it gets absorbed. And the concept here is that on a sunny day, visible light gets absorbed more by dark surfaces. So if you put a black surface out on a sunny day, it's going to get a lot hotter than a white surface. And similarly, this is how lasers work at a little bit more focused way. And so lasers have wavelengths of light, and those wavelengths are absorbed preferentially by different types of tissue. And as surgeons, we can utilize that to provide a very focused and targeted energy that can minimize some of the risks of less targeted thermal energy. And that energy will cause coagulation or vaporization of tissue, depending on how much energy you're using. And so the way lasers work are really three ways. So one is the thermal effects that we talked about. The other one is mechanical effects, in which it delivers energy to provide a shock wave, and this is what we use for stones. And then chemical effects, in which the laser actually alters chemical compositions to provide changes that are desired. So in terms of the thermal effect, the wavelength of the laser, as I said, approximates the absorption of the tissue. And the two things that we think about in terms of surgery are the absorption of water, and we know that the body is largely composed of water, and within the urinary tract, we're in a water-based environment when we're working. And then blood is absorbed at a lower wavelength, and the wavelength of your laser determines how things are absorbed. The photomechanical effect is not seen much in tissue surgery, but we use this frequently when we're dealing with stones. So we have stones that work specifically for lasers, and they basically create a shockwave effect to break up kidney stones. And then there's a photochemical effect, which isn't used that frequently, but it can be used for what we call tissue welding, bringing tissues together, as well as using photosensitive chemicals and inducing them to deliver their therapy in a certain area by using a laser. So I won't talk much about that, but it is kind of an interesting feature. And I won't talk too much about this, but these are all the different lasers we use in urology. And they have different wavelengths and different absorptions. And I think the most important thing to know is how these different absorptions and wavelengths translate into how deep the energy goes. And how deep that energy goes can alter the risk of side effects. And so the closer your wavelength is to water, the lower your penetration is. And the laser fiber that we've chosen for our enucleations, which is the thulium fiber, seems to have the least amount of penetration depth and should carry the lowest risk of significant side effects to things like sexual functioning in areas around where we're working. And that's important. So there are some new technologies that are out there that don't involve directly removing tissue usually, but can be effective. And I'd like to talk about some of those. And I'm conscious of time, so I'll try and be quick. So there's a newer treatment called aquablation, which uses a high-powered water jet. And it's actually a pretty neat technology in that it's robotically controlled, meaning that the size and shape of the prostate is plotted out, and the robot controls exactly how far and how strong the water jet is to precisely remove the prostate tissue. It's very quick. The downside is that it's not providing any energy that leads to control of bleeding. So often you have to go back in after that tissue is removed and control the bleeding. There's also the UroLift, which was recently cleared by the FDA. And basically how this works is it uses tacking sutures that hold open the prostate and lead to a larger channel. And this is essentially what happens when you use it. So this is an obstructing prostate on the left. And when you apply the UroLift, it pulls that tissue out and leads to a much more open channel, is very effective. It leads to the lowest rate of ejaculatory side effects and works quickly. The problem is because you're not removing tissue, how durable that treatment is a little unclear. And the data on this are still relatively new. So it's only been out for about 8 years. And we're just starting to see data in terms of the 5-10 year results. And they currently show that it may have a higher chance of needing additional procedures down the road, but it is certainly effective. Resume is another device which is fairly minimally invasive and it's quick. It basically generates water vapor, which is injected into the prostate and causes the prostate to shrink and retract. Over time, it's very effective and again leads to a fairly open channel. The downside is that it takes time for this to happen. So initially, patients can sometimes have even worse symptoms than before, but over time it does work and it is effective. As it is a newer procedure, the durability is also in question. but this can be done in the office with just local anesthesia. There's also a procedure called prostate artery embolization, where radiologists will inject microspheres to basically cut off the blood supply to the prostate. And it does seem to work. It does seem to be effective. It seems to have less sexual side effects than transurethral resection of the prostate, but the effectiveness of transurethral resection seems to be better. Also a new procedure where the data is very new, called Eaton. And similar to the urolift procedure, it uses a stent to sort of hold open the prostate and allow patients to empty more completely. The difference is that as opposed to being permanent implants like the urolift, this is meant to stay in for only about a week and then is taken out in the office. But it has been shown to be effective, at least in the short term, although the long-term results are still pending. And this is another busy slide that's busy for a reason. Just to say that all of these treatments have different advantages and disadvantages. And even if you come into your discussion with your urologist about one that you may think sounds better than another, it's important to know that depending on the anatomy, the size of the prostate, what may work best for you may not necessarily be the treatment that you may have initially thought makes the most sense. But working with your urologist to decide what your priorities are, as well as what may be the best choice for you in terms of effectiveness, allows you to choose a procedure that's going to work really well for you. Lastly, I just want to talk a little bit about what we're doing here in Newport and Lifespan in regards to BPH, and I'm pretty excited about where things are going. Currently, we have available urolift, transurethral resection of prostate, which is obviously the standard, laser ablation. Also for larger prostates, we're able to do robot-assisted procedures, which minimize those risks for the very large prostate. But as we're moving forward, we're moving towards getting the Resume procedure as well as also the Eaton procedure. But I think most importantly, and hopefully in the near future, being able to offer the laser enucleation procedure to patients in Rhode Island. And I think we'll be able to do that right here in Newport, which I think will be great for local patients and also potentially provide a destination for patients who either need who want the benefits of this procedure. And that's something I'm looking forward to and hopefully can begin to offer in the very near future. And just briefly, I'll mention we did one case with this back in November as sort of a demonstration. And this was a 57-year-old gentleman who was in urinary retention with a catheter. He had a very large prostate, 140 cc's is the tennis ball size, which normally would require a surgical approach involving incisions. And he underwent a laser enucleation. He was able to go home the same day. His catheter was out 2 days later. He was immediately voiding without difficulty, and he's 4 months out from his surgery now, extremely happy and voiding without issues. And he was able to avoid a stay of 1 to 2 nights in the hospital, a catheter for an additional 1 to 2 weeks, as well as longer recoveries and higher likelihood of transfusion. And I think it points out to some of the advantages of this technique and where we can go in terms of continuing to improve patients' outcomes when we're dealing with enlarged prostate. And so I will end it there and hopefully have a little bit of time for questions.
That's awesome, Sam. Thanks for taking the time to go through all that. And I can tell you that he did a abbreviated version of the presentation, especially at the end for our senior team. And the advantages and the science is pretty compelling for some of the procedures that he's talking about. So we're certainly all on board, and we're at the final stages of just getting the approval at the lifespan level to make sure that that all is on the up and up. And so very excited to be able to offer that laser enucleation procedure here. As you can see from this slide, a lot of potential advantages over some of the more traditional surgeries. So I think that'll be great. So thank you for going through that. I always learn a ton from these, and I certainly learned a lot. Who knew the prostate could be that complicated and there'd be so many different options for treatment? So just because you heard about something from a friend or heard about something on TV might not be the right fit for you. So the nice thing is Sam's literally right across the street from the hospital on Powell Ave. So we can certainly get you in to chat with him. But while you have a few minutes, I would like to open it up if any of the attendees, I recognize some of the names, and I know some of you can send out some pretty good zingers of questions. So please feel free to ask either Sam or myself any questions that you might have, either about urology procedures, medications, treatments, anything related to the hospital. We'll take whatever you've got, and we'll do our best to answer them if you have them. So please fire questions off into the Q&A or the chat. And I'll give everybody a minute or two to do that. And I just have one question that I got earlier, was just kind of around maybe describing specifically what you treat at Newport versus what you decide to take up to the Miriam. So maybe you could give some examples of, patients that you might treat here, do some procedures there, bring them back, how that might all work out for local folks.
Sure. I think for me, the goal is to try and treat as many patients locally here at Newport that I can. And essentially what that means is, for the most part, anything that doesn't involve robotic surgery or some of the more complicated stone surgery that needs some equipment that we don't have can be treated here. But for the robotic surgery, especially, that's something that requires a trip up to Miriam.
Excellent. Yeah, I know sometimes folks around here will end up with something pretty complicated or be in those prostate cancer situations where they need to have more complicated surgery. So it is great that we have the access to be able to do the vast majority of routine urologic care here locally and then send you up. But also you can follow them and you can manage them, and your whole group and partners also get involved in that. So it's great to keep that in the family. And then, of course, our partnership with the Cancer Institute in terms of their global cancer care with chemotherapy, other treatments, radiation, as you mentioned, we can coordinate those things as well. So.
Yeah, exactly. And I think that's really what I'm trying to do is, be able to offer the advantages of being local with also the expertise, some of which is required at sort of these bigger tertiary centers. And even if you need to go up to Providence for your surgery, the good news is you can continue following and continue most of your management down here, and that's really the goal.
Great. So one question that came in the chat box from George Petrovus is there an easy way to diagnose BPH, like the size of your prostate, other than just using patient symptoms? So any tricks to figuring out how big your prostate is?
So certainly, just based on prostate exam, you can get a sense for how large the prostate is. I'll say the issue, though, is that even though the larger your prostate, the more likely you are to have symptoms, there's plenty of patients who may not have a particularly enlarged prostate on exam, who just have growth in the wrong direction, meaning that it may not overall be enlarged, but it's growing in to cause constriction. So I think, if you have someone with a large prostate and symptoms, it's usually a pretty good bet that it's enlarged prostate. But even a patient, who's in the right demographic, who's having symptoms that are consistent with enlarged prostate, even if their prostate doesn't feel particularly enlarged, they'll often benefit from the same treatments that someone with a very large prostate would.
Excellent. Yeah, unfortunately, I've heard that it's just one of those things that just keeps growing and growing, like you mentioned. So that was going to be my question for you: is this something that we're all just kind of, it's inevitable and we're all going to have to deal with these sorts of things, or is there anything on the preventative side, anything that we can do to try to slow the tide, unfortunately, or slow the inevitability of having to come see you in the office?
Yeah, I mean, I think, I mean, there are the medications which are able to shrink and slow the growth of the prostate. The issue is that, those medications do come with significant side effects. And I think, that's, from a treatment standpoint, maybe worth it. From a prevention standpoint, maybe not so much. And I would say, the one thing is that even though everyone's prostate continues to grow, some people's grows faster than others. And, I'll see people in their 40s with incredibly large prostates, which is rare but possible. But I'll see people in their 90s who are going to the bathroom fine and have a relatively small prostate. So I think awareness is important. At this point, there isn't anything that really works, well to prevent.
Still a mystery. How do you be that 90-year-old with a regular sized prostate? That's the guy I want to be. So if you find out anything, if you hear, you let me know first.
Yeah, I'll give you a referral. And so I saw another question.
Thank you. Yeah.
So what age is recommended to start monitoring prostate? And I think in terms of monitoring for PSA, there isn't a blanket answer, but there are some guidelines. I think for patients who are at higher risk for prostate cancer, meaning patients with a significant family history, who are in a demographic group such as African American, who are at higher risk of prostate cancer, it's probably best to start PSA monitoring at age 40 if you choose to do so. For those who are at what we consider to be average risk, usually that recommendation is 50. Although there are some people who choose to start monitoring earlier, and there are different strategies for that. But those are sort of the two sort of standard recommendation timelines.
And then we'll probably time for this one last question. We had a question that came in the chat box too, just about kind of prostate cancer and BPH. It's so the prevalence with prostate cancer, obviously, as you get advanced stage goes up. So the question is, should you just do the prostatectomy and get rid of things to eliminate your future need for dealing with prostate cancer? Or is it better to just kind of treat the BPH and take your chances? So I know breast cancer, they talk about those sorts of things that will point to you. Just go ahead and say, you know what, let's just get rid of the organ and you don't have to think about it. Maybe you could speak to the pros and cons on that.
Yeah, I mean, I think, it's definitely something that people consider, especially in those people who are going to require a bigger robotic surgery already, where the thought is maybe if you just go in and remove it, that's the better solution. I think the issue is that, while, surgery for prostate cancer is effective, and we can do it with relatively minor side effects, the risks of that surgery are different. With surgery for prostate cancer, there's more risk of leakage of urine after surgery, and more risk of sexual functioning problems, which if you have cancer and you need the surgery, they're manageable. But if it's just an enlarged prostate and we can treat that in a way that avoids those side effects, I think that's still preferred. And, even for patients who have had other treatments for enlarged prostate, if down the road you develop prostate cancer and that needs to be treated, we can still do that safely and effectively. So that doesn't alter what we can do down the road if we have to. And if it's just enlarged prostate, the safety of doing a less invasive approach overcomes the risk of long-term issues.
Great. Yeah, these decisions of weighing what are the potential harms versus what are the potential benefits are the kind of discussions that we struggle the most with every day in all areas of medicine. So those are always great questions. And my recommendation is similar to Dr. Eaton's, which is just, sit down and have a conversation about your unique situation with the urologist just to decide what the best course of action is. knowing that with all of these options, there's probably one that's a good match for you. And just because you've had one doesn't mean you can't potentially have a different one down the road. And hopefully you'll get that sort of longevity of the procedure and not need to have additional work done. But it's good to know that the technology and the techniques have advanced to a point where the risks are really getting less and less, where we can actually have those conversations of, is it worth just getting rid of the prostate? Because it's actually getting to a point where the risks are getting pretty minimal. So that's great news for anybody that might need to have some sort of procedure in the future.
Yeah, and the last thing I'll say is that when we're considering surgical treatment for enlarged prostate, that's one of the things that we think about, is making sure that there isn't cancer there, so that if it's something where we really do need to treat for cancer, that we're not doing something that, you know, is going to be less effective and then need another treatment down the line. So we do try and prevent that when we can.
Yeah, that's a great point for sure. So, all right, well, I want to be a little sensitive to everybody's time. I really appreciate the attendees that were able to jump on, and thank you for the questions. And thank you very much, Dr. Eaton, for taking the time to go through this presentation to educate us all on this information. And thank you for bringing your expertise and the technology and all of this really evidence-based, cutting-edge urology treatment to Newport. It's yet another example where a little Newport Hospital can somehow or another have some pretty cutting-edge, amazing treatments available here locally. And then the advantages of being tied in with that institute up at Miriam, should you need something even more sophisticated. And your doctor can actually, in this case, follow right along with you. So you'll have a familiar face when you get up to the Miriam, which is awesome. So I really appreciate you taking the time to do this. This was recorded. So for those that were able to join, I noticed Danielle Sandoz, one of our marketing folks, she's on the line. Eric Gabrielson, my assistant, they'll help us be able to distribute this as well, because I'm sure we'll get questions or people that weren't, for whatever reason, able to join tonight. So we'll be happy to send this out and present it as well. So thank you, everybody, for joining. Thank you, Dr. Eaton, for taking the time to go through all this. And thank you, everybody, for the questions. For now, we will sign off for the community lecture series for this month, and we will get prepared on our next community lecture series coming very soon.
Thank you so much.
Really appreciate it. Thank you. Everybody have a great night.